Hello, hello, good evening. Tonight, we are diving straight into the great myofunctional therapy debate. I'm going to apologize in advance on the off chance that I keep you over time because there is a lot to cover, and some of it may be surprising. For those of you who are not surprised, I applaud you. For those of you who will be shocked and in awe, I applaud you. Thank you for showing up. Give me a hi, hello, whatever in the comments. Just let me know that you can hear me, you can see me, and I am not just, talking out into the void with nobody really able to understand what's going on. So welcome, welcome, welcome. I am so happy to talk about this, but it really grinds my gears. There are a lot of misinformed people in the field, and I don't want that misinformation to be perpetuated. So get ready, sit down. I'm going to challenge some of the beliefs you have. I'm going to challenge some of what it is you think you know. And I am honored that you're here to even take a different perspective, because that's my whole thing with this field. The field has a tendency, and my husband told me to stop saying this. He's like, don't say it. Stop saying that it's like a cult. But it is. It's exactly like a cult, where it's like, if you don't believe everything we believe, it's a problem. And it's not a problem. It's not a problem, guys. It's something that, yes, we do have to work on, and we can work on, and it's going to get to a better place. But it's just that awareness, that enlightenment, because as far as I'm concerned, everybody who's in this field, in the legitimate, and that's quote unquote way, that is something that you're a licensed professional. You should know a lot about research and understand and be able to really digest this topic in a very beautiful way. So let's talk. Let's dive in. Okay. Dr. Eric Kazarian. I hope I'm saying his name correctly. I apologize if I am not. I do want to let everybody know also in advance that my Myopathway logo's on the bottom. I talk about this blog all the time. I have a whole lecture in my Myopathway program, my comprehensive myofunctional therapy course program, a whole section dedicated with CE, dedicated to evidence-based reading and research, and really understanding how to differentiate between the two. So since there was a lot of shared slides, I'm just keeping the logo there. So if you're annoyed, if you're like, oh, it's an ad, no, like this is stuff you should have been taught in your intro program. And if you weren't, it's time to start reflecting backwards. Okay. All right. Dr. Eric Kazarian. Dr. Eric Kazarian, and I apologize so deeply if I'm saying his name wrong. Not that I ever think he will watch this, but in 2018, this blog post was posted, and he legitimately posted this thinking that nobody's really going to read it. Like, who's even reading his blog to that extent? But boy, oh boy, was he wrong. So this blog essentially took a fine-tooth comb to oral myofunctional therapy and the idea of tongue ties and tongue tie release, specifically frenuloplasty, okay? Frenuloplasty as being an adult thing, okay? So a lot of this article, where he is advocating, is saying, look, I understand that oral myofunctional therapy is a thing. I've been to Brazil. I have read the research. I have done the work that it takes as a ENT. He's an otolaryngologist and a professor at UCLA. He's done the work, and guess what he found? There is no legitimacy to any of the claims that myofunctional therapy or functional frenuloplasty or dysfunctional frenuloplasty have any impact or effect on obstructive sleep apnea in adults. Huge caveat. He's like, children are still growing. There's a lot, whatever. So children are a whole different thing, but we'll get into that. We will get into that for sure. But children are an entirely different thing. And I love this because it's so true. Immediately I read it and I'm like, you're right. Like I didn't question it whatsoever. But then you get to the comments and you're like, oh, Zagi's here, Lamberg's here, Gelb is here, Linda D'Onofrio's here. She's posting links to research. She's there. Like everybody's there. Christian Guimeno is there. All the people are there. Everybody's there. And they're like, ah, no. And I know somebody's going to comment about that. I'm so sorry. But they're like, of course it is proven. Look, we have this study and this study and this study. And at that point, I think Zagi was still working on his whole 348 case, research cohort. And that, we'll talk about that too in a second. And that wasn't out yet, but he's like, we're doing the research. Only to find out that guess what? We are here today in 2024 and nothing has changed since 2018. There is still no research that proves that oral myofunctional therapy done the way that it is done in America is legitimate, okay? And we're going to go through this step by step, okay? So in addition to posting that blog post, he actually did a whole video about it. He is super monotone and like very difficult to listen to for hard periods of time. I tried to pick like the best areas. And so let's see and hear a little bit of what he has to say. Then I'm going to cut him off. I'm going to start to explain some of it and we'll bring him back a little bit later, okay? So let's get into Dr. Kazarian. By the way, this is the only time you'll see his face is in that little preview.
Here's Zagi and I have shared slides so that we can have a real pro-con discussion. So we'll review some areas of agreement.
With Dr. Zagi.
First, mouth breathing is unfavorable for obstructive sleep apnea, or technically for sleep disordered breathing. There are multiple potential mechanisms that have been studied. One is the fact that mouth breathing often occurs with nasal obstruction, and that obstruction of the upper airway is not ideal. Mouth breathing is also associated with posterior displacement of the tongue, a mechanical effect that occurs because the mandible swings down and back with mouth opening, moving the tongue with it.
I just want to pause for a second there so that you know that he was even on that bit of research that mouth breathing is unfavorable for obstructive sleep apnea. So he doesn't disagree. Mouth breathing is absolutely a problem. Sleep disordered breathing, it's definitely a thing, okay?
Finally, there are some reflexes that help to maintain an open pharyngeal airway that depend on airflow through the nose, such that mouth breathing may decrease the reflex activation of pharyngeal dilator muscles. I have included a reference to a review article where I was a co-author, but this was neither the first nor the last review article to summarize the literature on this topic. We also agree that the tongue is a major source of airway obstruction for many adults with obstructive sleep apnea. However, we disagree in a number of areas that are unproven. There is just no evidence to support the idea that OMT can convert someone from mouth breathing to nasal breathing. You can do all sorts of nasal breathing exercises, but I have never seen studies showing this effect.
Please let that settle in because we talk about it a lot. And in the courses I teach, I've always said you'll never get anything other than proper oral resting posture. I don't know what everybody else is teaching. I don't know what everybody else is out there believing, but we still have no research that connects oral myofunctional therapy, oral pharyngeal exercises, oral nasal exercises, or anything that we do to nasal breathing. Just let that digest, please. It's a thing.
Focusing on tongue position with quote-unquote exercises during the day have never been shown to impact tongue position during sleep. It has just never been shown. Furthermore, the treatment of ankyloglossia in adults, whether with frenuloplasty or anything else, has never been shown to affect tongue position during sleep. Lastly, there are no studies showing that frenuloplasty combined with OMT is a treatment for adults with obstructive sleep apnea, making frenuloplasty an especially unproven approach. The idea that OMT and frenuloplasty are treatments for adults with obstructive sleep apnea would require proving these, and we are not even close.
Okay, so he did this, and I promise we're going to get into all of this. He did this video. So he did the blog in 2018. He did the video in 2020. Okay. Later on, he talks about what he didn't like or why he disagrees that Zagi's cohort was an actual cohort or legitimate research in the way that it was posted as, a systemic review. And we'll get into that. Okay. Trust me, I've got the slides. We're going to move. Okay. So essentially, what we're learning at the end of all of this is that oral myofunctional therapy, oral facial myology, oral facial myofunctional therapy, or whatever you want to call it, it's not a thing. It doesn't really exist. By the end of this, you will settle with that, you will understand it, and you will live in a better space mentally, and you will stop sending people research without the caveat that, like, the research is questionable. Okay. To know and discern good research from bad research, you're going to need to understand research. And I know I talked about this a couple of weeks ago for those of you who saw the ortho lecture, but I'm telling you, the more you drive this and drill it into your brain, the better you will feel. Okay. So there's a hierarchy. There are levels to this stuff. Okay. The highest level is a meta-analysis or a systemic review. There are articles titled meta-analysis and systematic reviews, but they're easy to kind of just throw off to the side. We'll get to that. These are the highest level because there is a method to the madness. So for a systematic review, there are steps you have to take in order for it to qualify. There's protocols you can follow in order for it to qualify. There are publications and journals that will not publish if you have not met that criteria. Alternatively, there are other journals that will happily publish just for the sake of having an article, or they don't hold themselves to that high standard. Knowing the difference between the two, because everything that shows up on PubMed isn't like the best thing in the world. Knowing the difference between the two is incredibly important, okay? What we really have is down at the bottom, a lot of individual case reports, case studies, and I don't think we even have any cohort studies. I mean, we can say that we have maybe one or so in Brazil, but we really don't have the cohort studies. These studies are going to be in some sort of regulated method. So they're going to have a method to the madness, something that they can test and they can prove. We ask a question, hypothesis, we're going to prove it, and it's on a limited number of subjects. When it's on a limited number of subjects, that's the first thing you have to ask. If you are reading a research paper and that research paper says that they have worked with under 50 people, under 100 people, under 500 people, under 1,000 people, we are nearing, I don't even know if we crossed it yet, but 8 billion people on this planet. What are the odds that I could really replicate whatever your results were on this 100 population? What's their diet like? What's everything else that goes along with a lot of what we do? Okay. What's the diet like? Were they doing anything extra as far as like body work, manual therapy? Like, how am I really judging that I can replicate this realistically unless it's controlled? Meaning that you know exactly what's going on in these people's lives. Like, they're probably very well monitored, heavily monitored throughout the day. The protocol is monitored. You've got to compare a comparative cohort of people. So you've got two different groups. One is heavily controlled. The other is also controlled, but they're more of your placebo placeholder. So they might not be doing myofunctional therapy exercises. And then the other one is doing myofunctional therapy exercises, or they might not get a frenectomy. And then this group might get a frenectomy, and then yada, yada, yada. Okay. So there's two different controlled environments. That's what puts those right in the middle. Critical analysis of those controlled studies, that's what makes like the top part of the pyramid, meta-analysis, systematic review. If you are lacking any of that, okay, you've got a pseudoscience. The pseudoscience is going to lack repeatability, reliability, credibility. It's essentially anecdotal. So I get it. I've had a lot of patients who have gone through, I have hundreds of completed cases, hundreds of completed cases. I can tell you about the people who have cosmetic changes, the people who have genetic defects that we work and we collaboratively work with other providers, and myofunctional therapy, I think, was essential to that success. I have people who have come off of CPAP, people who have come off of like lucid dreaming, who have had like all these different things going on in their life. Terrible headaches, jaw that would lock, the physical therapist, PT. The PT that I worked with that had lockjaw once a week, that was beyond my comprehension. Like how you were living with that for like the 5 years she was living with that, I don't know. But we've done myo and come out of that. None of that means absolutely anything. It means nothing. Your clinical experience, my clinical experience, they don't count as evidence. It's not evidence that proves a truth. You have to be able to repeat it with a reliability and over a span of time and a span of people. And then let's talk long-term studies. What's going on with the people I worked in 2017 with? It's 7 years later. How are they? Are they good? Can we study the long-term retention? What have they done in that time? Any relapse? Like you have to have these long-term things, and 7 years isn't even that long. We'll get into, and I keep saying we'll get into, but trust me, we're going to get into the research, and you'll see that there was one long-term one that Christian Guilleminault was even a part of. But again, it was with children. So there's still no evidence for adults. And even the evidence for children is a little questionable, okay? Because what we define as oral myofunctional therapy matters. Okay, so here we are, August 2020. August 2020, he produces that video that we saw, and he doubles down. It's been 2 years. Y'all haven't shown me anything, is essentially what he said. 2 years. You haven't shown me not a thing. Nothing. Where's the evidence? There's no evidence, okay? So he has gone above and beyond to now present this topic and put it out there on YouTube. There's only 2,000 views, so don't worry. The few people that do care about myofunctional therapy surely haven't watched it. It's not like it's gone viral, but that whole 40 minutes, maybe it's a 50-minute lecture, but that whole lecture that he presented about oral myofunctional therapy not being proven was for the International Surgical Sleep Society. And so there's a bunch of surgeons who probably are very upset. And this is probably why your ENTs are not collaborating with you. So I think this combined with just the frustration from the continuous comments, so the comments kept coming, it's really something that he felt he had to address again. And he addressed again with a combination of other things. So he's like, it's not even just myo that I have a problem with. It's not even just frenuloplasty that I have a problem with. I have a problem on a whole with a bunch of different things, with a lot of things that they are claiming. They is not like a true they, but people are claiming help with obstructive sleep apnea, and he knows that they don't. So let me get this to play.
It is time for all of us to speak up about unproven treatments. Adult patients with obstructive sleep apnea definitely need options, including non-invasive approaches. In many cases, these patients are desperate when they do not do well with CPAP or other therapies. There has been a surge in advertised yet unproven interventions, and it really is disturbing. The marketing has far outpaced the science. For example, with appliances advertised for facial growth in adults that are also completely unproven, but provided to patients at a cost of $50,000 US. I have seen this all for a few years, and I wrote about OMT and frenuloplasty on my little blog in 2018, saying much of what I'm saying here, that there might be a role in children, but that there was no proven role in adults with obstructive sleep apnea. With my minuscule blog audience, I thought it might get read by my mother and 5 of her closest friends, because nobody, not even my own young children, pay attention to anything I have to say. Instead, there was a flood of angry feedback and comments on the blog and elsewhere online saying that I was just a surgeon who wanted to badmouth everything other than surgery. I did actually hear from some leaders in OMT expressing that they actually agreed with what I wrote and thought it was a disservice to patients with sleep apnea and to the field of OMT that providers were out there marketing themselves as able to treat sleep apnea when no evidence existed. However, the overall tone was definitely one of anger. I engaged as many people as I could, going to their Facebook group once invited and answering all posts, hoping this would spur research, just as so many have critiqued sleep surgery as I still do and have led to research in our own field. Instead, here we are 2 years later with plenty of marketing and pretty much no more research. Christian Gilmano himself was a major proponent of OMT who has sadly passed away. But after my blog post, he actually commented with a long post about how I was wrong. Yet I was disappointed that he could only cite pediatric studies in an attempt to refute me. In essence, I was right in thinking that there was no evidence in adults. I will just say that some people who admired him, including me but also others, think that this is one area where he did real harm to adult obstructive sleep apnea patients.
Okay, I'm going to rewind him just a little bit so that you can see what some of his issue was and that he talked to Zaghi about some of his issue with that cohort study that was published. And then we'll move forward, and I promise I will get you research. We're going to talk about looking at research with a critical eye. Okay, it's not this one. Where's Zaghi's study? Hold on, we're gonna get there. This is the meta-analysis. We're gonna talk about the meta-analysis, but I want that cohort study. Hold on, we're gonna get there. Okay, I'll figure that out maybe another time because I don't know why I'm not finding it. There was a whole thing about that study because everybody wants to quote that as like, oh my gosh, that's the thing. He worked on 348 patients, but don't worry. Don't worry. Okay, we'll get to that. I'll figure it out. Maybe at the end, we'll come back several slides and figure that out. Okay, moving forward. So all of that prompted him from 2020. He did that presentation and he went and did his own sort of research and cohort to do a review. And in that review, like, annihilated a bunch of different things that were going on and a bunch of different things that were being marketed. So whether it is, whether it is a pillow or a appliance or expansion or frenuloplasty, we've got low-level studies that really don't prove much of anything. And on top of that, for OMT, we've got no system at all in America for how it's done, how exercises are prescribed, who teaches, what's the criteria for that, what does certification mean? Like, it's all really non-existent. And in a way, and he describes it so beautifully, in a way, it makes it seem as if the whole system is there to scam providers out of their money to then subsequently have them scam the general public out of their money. So when you're presenting evidence and research, it's really important to be able to be objective because you're a licensed professional, you are educated at a high standard, and you should continue to educate yourself at a high standard. CE is always supposed to be with like real evidence-based methods that are behind all of the stuff that you are presenting in any level. So whether you're presenting it at a study club and you're giving people 1 CE, or you're standing in front of a team at a dental office and doing a lunch and learn, it's supposed to be, if there's CE involved, evidence-based, okay? So there's a little bit of question that you have to always have as a provider, in my mind, if you're a provider of quality. Okay. So 2023, last year, he doubled down. We're not in August 24 yet. So who knows? He might come back again. And his whole thing was like, stop publishing systematic reviews of myofunctional therapy. There are several around. And in these, there's no reason that they should be even called systematic reviews, because there's critically low evidence that is proven in a lot of these. And sometimes the protocols and everything is so different. It's so different. So it's not something that you want to have. I don't want him to write another blog post about it. I want the field to now represent itself better, and to say, you don't have to say that you're a pseudoscience, okay? There's, I think, enough evidence of such at this point, before we've ever gotten into the research. There's enough evidence of such that we are a pseudoscience, but you can think of it the way you would think of other things that have gone more mainstream than oral myofunctional therapy has, and in my belief, ever will. Okay, I think we'll get bigger than where we are now, but we'll never be as big as like energy work. So Reiki, the people who read tarot cards will be household names for decades longer than oral myofunctional therapists will. But Reiki, energy workers, people who do acupuncture, people who do sound therapy, sound baths. Like sound baths are like a household thing. Everybody understands what that is. And, you know, there are people who are ringing gongs or tapping on drums or rubbing on the bowls with that little round thing. I can't think of what it's called, but everybody's got some sort of awareness. When I say a sound bath, you've seen it, at least on TV, if nothing else, you've seen it. Okay. Face yoga is bigger than where we are with myofunctional therapy, but all of those things are widely accepted. And I don't think anybody's ever asked, hey, you got any proof about that sound bath? You got any systematic reviews about that sound bath? No. It's like, oh, it's a little hokey. Sounds like it might be something that works. All right, let's do it. Just like that. Myo can be equally as, sounds a little hokey, but it might be something that works. And there are people who would swear by a sound bath, people who swear by Reiki. I'm one of those people who swear by it. You know, rhythmic movement. I'm all about all of the things. But if we can get to that point as a field where we're accepting of what it is, and we stop pushing it as like some evidence-based thing, and we start pushing it for what it really is, something that is a dynamic aid to help you on your journey. In what method? I don't know. Proper oral resting posture. It's great. Like in what way does a sound bath help you? Vibrations in your ear, like I could do that without that. I can do vibrations in your ear, you know, just give me a tuning fork and we could do that, vibrations in the ear. So in what way is a sound bath helpful? Nobody's out there trying to throw out some research about it. So I would like us to stop trying to get to the research, because a significant amount would have to change in what we do in order for us to get there. Okay. Here are some of the things that Dr. Kazarian was very, very adamant that we really stop having talks about this helping for OSA, positional aids, nasal valve inserts, mouth closure, chin strap, tapes. There's no proof for that. I really wish people would stop doing the mouth taping, but that's a box that I will step down off for today. Oral pressure therapy, didgeridoo, DNA appliance, orthotropic appliance, oral pharyngeal exercises, myofunctional therapy, frenulopathy, like it's all in there. So he's like, I don't even hate just myofunctional therapy. I hate all these things that people keep saying, oh, we've got research and we're FDA approved and we're you don't have sound research for a lot of this stuff for the treatment of obstructive sleep apnea. Now, does that mean that it doesn't help? No, you just haven't proved the effectiveness outside of whatever your clinical experience is. So he always wraps it up with like, he hopes that people would stop marketing it as evidence-based and would start producing more research, start raising the standards in the field, start establishing standards in the field so that providers are more willing to work with you if they are research focused. And let me give you a heads up. ENTs, surgeons, like heavily research focused. They can't just go off of evidence-based. They can't just go off of your clinical experience. They have to go off the evidence. So when they're asking you to send them stuff, and so people who say, I'm trying to network and I've been sending, and what kind of research do you think gets the best, response? Like, what kind of research should I send to an ENT? Should I send to an oral surgeon? Like, how can I prove to them that myofunctional therapy is something they should be working with? You can't with research, boo, because if they've ever read any type of research with any critical eye, they're going to dismiss you right off the bat of you sending them the research. So start talking about it differently. Start talking about it as something that is more of a holistic way of, working with the patient. So if you have a patient that's a little resistant to doing things through the traditional medical model, and they're more likely to skew more towards, holistic options, and you think that they're going to go home, not fill their CPAP prescription, and they're just going to go home and they'd rather do nothing, or they're going to buy something, pardon my language, crappy over the internet, perhaps sending them to a myofunctional therapist for anything, at least a conversation about what some of the more natural options might be. So while I don't have clinical evidence that stands the true test, because I don't, honestly, what I do have is that I have these patient testimonials. I have these cases that I personally worked with, and I can tell you that if we collaborate, I'll do a case with you, and I will be as transparent as possible, because that's what the field really lacks, particularly within the dental side. A lot of transparency. You have people who are so nervous, so scared about somebody in their territory, or somebody stealing patients, or oh my gosh, that we're not even like on the internet sharing information just for free amongst each other so that we can grow and benefit together. We've got so much of like, hush, hush, you don't want to know what's going on in my program. Or if you do, I just need XYZ amount of money, right? So let's do better. His hope for the future is my hope for the future, that there will be more research, a little less marketing, and more like transparency in the field, that we will grow together in a more positive way. Okay. So again, remember what's good research and the hierarchy. So when we're looking at systematic reviews, they're supposed to be up top, but there's a criteria. You can't just have something, call it a systematic review, and have that be the end all be all. So the criteria that goes with a systematic review, you have to ask a clinical question. It must be very specific, something that we can answer with like a yes or a no, but very, very specific. It has to perform a comprehensive literature review. So you're looking through a lot of literature. I've done a literature review before for periodontal, and there's a lot of research behind periodontal disease. We know that's a thing, right? Behind periodontal disease. And unfortunately, I included some articles about frenectomy and so forth. But the literature review is actually one of the most important things, because in your review, you have to eliminate studies that were poorly done. That's a big thing. If you don't get rid of those poorly done studies, your literature review is trash. It's absolute garbage, and it shouldn't be published. And then you have to make recommendations based on well-done studies. So you're going to take all the good ones, you're going to review them, go over and compile all the data, and then here's the answer to the question with our recommendations based upon that. Okay. So systematic reviews are only supposed to include experimental or quantitative studies, and often include randomized controlled trials. There are a couple of controlled trials, and you'll find that a lot of them are often with children, those pediatric studies that are higher quality. So let's take a critical eye to our systematic review by, Dr. Camacho, Dr. Zaghi, et al. Okay, so this study was done by a group of phenomenal researchers and otolaryngologists and, physicians. They were fantastic. They took a critical eye to the question, does myofunctional therapy serve as a treatment for obstructive sleep apnea in children and adults? Okay. And they focused on studies with meta-analysis on the PSG, the sleep studies, the snoring, and the sleepiness scale. So they went through a bunch of different articles, whittled it down to 9 adult studies and 2 pediatric studies. So that's 11 studies. Okay. So it's 100 and just under 150 patients, roughly 145. The keywords that they used when they were searching through all of the major journals, the keywords that they searched were exercise therapy methods, myofunctional therapy methods, obstructive sleep apnea, and sleep apnea syndrome. And so from that, they got a bunch of studies. Now, their word for word, I should have put this in quotes because it is their word for word, their selection, okay? So how did they choose these studies? These studies needed to report quantitative polysomnographic snoring and or sleepiness data pre-treatment and post-treatment. Or they needed to report the percentage of difference between pre-treatment and post-treatment outcomes. Okay. Studies in which the myofunctional therapy patients also underwent additional interventions. So if you had all of that data, you had the quantitative data for a polysomnogram with snoring or sleepiness scales, you had all that filled out in pre and post, but you did myofunctional therapy and CPAP or myofunctional therapy and mandibular advisement, myofunctional therapy, and you did a surgery or allergy management, weight loss, or any other intervention, anything, expansion, if you did anything that could contribute to improving your sleep, so you did something more than myofunctional therapy, those were excluded. Okay. So it sounds like everything is going really well right now, right? So 226 studies they found using all those keywords, 204 were excluded. That left us with 22 studies, but 11 of them just did not have the right criteria. 11 of them did not function the way that we wanted to function. Sorry, I had to plug in my laptop. Okay, that left us with 9 adult studies and 2 pediatric studies. We will get back to the adult studies very shortly. The pediatric studies, one is a Guilleminault et al. Study about the critical role of myofascial reeducation in pediatric sleep disordered breathing. That was published in 2013. And that really came down to a question about puberty possibly playing a role in OSA after being cured through adenoidectomy. So what they did is they had a bunch of post-adenoidectomy. So they've had adenoidectomies and they're already healed, and we don't want them to redevelop obstructive sleep apnea once they hit puberty, hormones change, and there's fluctuations. Who knows? Things are going to happen, maybe. So that's what this study was all about. So Christian Guilleminault et al. Is looking to say, okay, we have 24 patients already, a low number, but okay. We have 24 patients. We're going to send them all out to an orthodontist and a myofunctional therapist. 11 of them received myofunctional therapy. So they had orthodontic treatment done. I think all of the 24 maybe had orthodontic treatment done, but only 11 of the 24 did the myofunctional therapy. And they did the myofunctional therapy for 24 months, for 2 full years. There is zero mention in that study as to what the protocol was. So we have to assume it's randomized. It is of the provider's choice. Where was that provider educated? Who knows? I don't know. What is their process? Who knows? I don't know. Like, nobody knows what happened in those 24 months, but they did oral myofunctional therapy, something that we know to be heavily compliance-based, but they did it for 24 months. This cohort got back in touch with all of the participants, all 24 of the participant children, and did a polysomnogram right after, within a 24 to 50 month window after. So myofunctional therapy, and those groups who did the myofunctional therapy, whatever that was, all of those, no obstructive sleep apnea. And then the 13 that didn't do the oral myofunctional therapy, all of those had some degree of obstructive sleep apnea. So it sounds very legit, right? You're like, oh my gosh, they did myo. Like, this is something you want to share with patients. You want to share, look at this. They had an adenoidectomy early, and that's not the only thing. They need the myofunctional therapy. If they don't do the myofunctional therapy, look at this study here. Everybody who didn't do the myofunctional therapy winds up getting obstructive sleep apnea after puberty. It sounds about right, but are you doing 24 months of myofunctional therapy with every one of your patients? What is the duration or frequency of time that you're meeting with them? What is your protocol, and how does it match the protocol that is there? How can you guarantee the results, especially on something that's so heavily compliance-based, right? How can you guarantee the results that will mimic this controlled study? And just right there with the crickets, it's like, okay. So one, it's not a large sample size. It's 24. We don't know what kind of socioeconomic status there is, what kind of external factors really play a role. You know, is it a two-parent household where there is somebody there to support? Is it a well-to-do area where this well-to-do area, they have nannies, and then nannies are there full-time and they're doing the exercises with them and they're able to really, we have so many variables that are unaccounted for that we don't know that we could replicate this again and again and again. So really, that should have been thrown out because you can't replicate it. We don't have any data on the myofunctional therapy in that paper. Second one that was put out, okay? This is Dr. Vila et al. Oropharyngeal exercises to reduce symptoms of oral sleep apnea after adenoid tonsils are extracted. Okay, adenoid tonsillectomy. So post-adenoidectomy, 2 controlled groups. So they did control them. They gave them exercises for 2 months, okay? 14 of them did exercises, 13 did not. So they had 2 control groups. They gave the group of 14 all the exercises and 13 did nothing. So you can compare it, right? Placebo effect. You can be like, hey, is this gonna work? Because sometimes people in clinical trials, it's a thing. Not doing anything somehow works for them. Taking a sugar pill somehow works for them, right? So what's gonna happen? Well, my first question is, what exactly are these oropharyngeal exercises? I'm so glad you guys had the same exact question. Here it is. Here's the list, okay? So you're going to blow up a balloon, breathe in through the nose, out through the mouth strongly enough to displace a balloon. You're going to breathe in through the nose, out through the mouth using a straw, placed in a glass of water, and make bubbles for as long as possible. You're going to breathe in through one nostril and out through the other, using the thumb to close the other nostril. Now, here's something that I really despise. You know what really grinds my gears? People who tell others to pinch their nose or to collapse their nose. Now, we've got a population of people, as oral myofunctional therapists, we have a population of people with narrow nostrils as is. We talk all the time about soft tissue pressures. And then we as a field openly promote pinching nostrils, like teaching nasal tissue to be smaller, that's outrageous. So I always cover from underneath. If I am ever telling somebody to block a nose for any sort of purpose, typically it's nasal hygiene and nasal hygiene alone, that I will have them block their nose for whatever purpose. But it's bizarre for me that you would spend 2 months like pinching down your nose multiple times a day. Oh, by the way, we also don't know the frequency at which they were doing these exercises. So it could have been just one time over once a day, 3 times, 5 times a day, or whatever. We don't know that. So breathe in through one nostril, breathe out through the other using the thumb. Lower the upper lip over the incisors in such a way to hamper contemporary relation of the chin muscle. Place a button tied to a string and pull it perpendicularly forward. Press one lip against the other, keeping the teeth closed. Vibrate the lips, blowing out noisily, and then place the tongue on the incisor taste bud and move from right to left using a movement resembling that of a windshield wiper. These were the exercises that were given to these 14 people, and it was very successful. How many of you are practicing oral myofunctional therapy? How many of you are actively giving people this exact set of exercises and nothing more, and then limiting your therapy to only 2 months? Nobody. It's not a thing. So the criteria upon which these exercises are picked, it's not a thing that is replicable because we don't do it like that. It's just not the way that it's done, right? So you have to ask yourself, like, what is it that we're really doing? Because it doesn't seem like what we're doing is evidence-based in any way when all of the studies that we have aren't really putting together what we do with what's actually out there. And then we hand off these papers like, look, this is what it is. So when you see that kind of graphic in there in the research that you're handing out to people, I mean, if I'm an oral surgeon and I'm like, okay, this works in pediatric patients, I'm just going to print off this thing and have my patients do these exercises. What do I need you for? I don't. There's no reason to listen to you, right? It's like, why? Okay. All right. Adult studies. So for these adult studies, what is interesting is that one of the adult studies, one of the conclusions was that there's no evidence of the utility. So the adult studies, we're still in that systematic review. We talked about the 2 pediatric studies. This is the adult study for our systematic review that's supposed to prove that oral myofunctional therapy is effective for obstructive sleep apnea, okay? So one of the conclusions is that there is no evidence of the utility of myofunctional therapy for treating upper airway resistance syndrome, the duration of the effects of myofunctional therapy, because there's no long-term studies, or regarding which myofunctional therapy protocol is best. Despite these knowledge gaps, the available evidence suggests that myofunctional therapy is safe. It's relatively safe. You can't really mess anybody up with it. You can't. So it's pretty safe. The only issue I have with that is that UARS is not a thing. Okay, so oral myofunctional therapy, OMT, is not a thing. UARS is also not a thing. From way back, I know Christian Guilleminault, he discovered it. He's like phenomenal. And there is physiological difference between obstructive sleep apnea and upper airway resistance syndrome. But let me tell you that the American Academy of Sleep Medicine has not declared upper airway resistance syndrome its own separate diagnosis. So it's not a thing. It is a mild form of obstructive sleep apnea. And so if you have the heart rate variability, but you don't have the apnea-hypopnea index, what would come up as per how it should, as per the American Academy of Sleep Medicine and the way that the sleep physician should describe your diagnosis at that point, is mild obstructive sleep apnea, not upper airway resistance syndrome, okay? So here's the little paper on this published in the Journal of Dental Sleep Medicine. And it's a very prominent thing in dental sleep medicine that upper airway resistance syndrome is not a thing. It's not something that's a defined diagnosis. You can talk to your patients about it, about the difference in heart rate variability and whatever. You can talk to them about it. But does upper airway resistance syndrome exist discrete disease state? Short answer is no. Okay. The independent existence of UARS from obstructive sleep apnea syndrome, cannot be supported based on the current literature. So just like you can't support myo from the current literature, there's not enough evidence about upper airway resistance syndrome, and it is like the darling of the airway community. Everybody wants to talk about that. It's the thin women. That's what they have. They may not have obstructive sleep apnea, but they have upper airway resistance syndrome. Guess what? They have obstructive sleep apnea. Like, that's what it is. It's a mild form of obstructive sleep apnea. That's the official diagnosis. And you have to talk to them in terms like that, because your sleep physicians, they know better, okay? Instead, it's considered a mild expression of obstructive sleep apnea in the continuum of increasing upper airway resistance associated with neurocognitive changes, okay? So that's one of the problems that I had with this adult study. But let's keep going on, okay? The issues that they have with oral myofunctional therapy are blatantly written all throughout. So to have a systematic review where it seems like you're trying to validate something that one of your 9 adult studies are saying, there's nothing here about myofunctional therapy that is a proven thing, nothing here that we should really rely on, but it's safe, is probably the most problematic part of doing a systematic review, and including a study that pretty much unravels everything that you want, right? So here's some important questions that they asked and answered. The effectiveness of the following factors has not been established. Home-based versus supervised exercises. So if they're at home doing it all their own, or if they're coming in every day and doing the exercises, the duration of the program, the myofunctional therapy program, and passive versus active exercises, like what's the criteria for even choosing all that? All of the available reviews and meta-analysis have mixed data by assuming that all techniques and all protocols falling under myofunctional therapy are equally effective, which is probably wrong. And they put probably, but it's absolutely wrong. It's absolutely wrong. What I do in my program has nothing to do with what anybody else does. I mean, I can't tell you the amount of messages I get in my inbox with people saying that they're stuck somewhere, or they're doing this, or they're on session 7 and they can't get somebody past. I'm like, what is session 7? What does that mean? I have no idea what that means. Like, where were you educated? I just really want to know. There's no equivalency amongst all of the myofunctional therapists. What I do, what you do will always be different, especially in America. In Brazil, they have a higher education system, and that higher education system, in the similar manner to how you got whatever licensure you had. You had to go to school, take a board exam, and and that made you this licensed professional. Anybody who went to hygiene school, anybody who went to dental school, anybody who went as an SLP and you went and you got your education, it's probably very similar, because there are standards, there are accrediting bodies that will determine what your education could look like and what really most of us will do generally the same. And so now when you're talking about dental hygiene, you're talking about a set of protocols for periodontal protocols, and what we do for traditional prophylaxis or oral hygiene instructions, oral nutrition guidance, and so forth. We're talking about a set of standardized educations and protocols. Myofunctional therapy doesn't have that, okay? Again, we're going to keep going down, okay? It's noteworthy that none of the selected authors focused on proprioceptive training. Hallelujah. I was so happy when I read that. I can't even tell you how long ago I did that. But proprioceptive training is where I begin. I don't start people off with myofunctional therapy exercises. Why are y'all even doing that? Where's their proprioception? Do they have any interoception? Where are their motor skills at? You really don't know, but there's no real talk about that in our global biofunctional therapy community. So I find it really wild that people are even, mentioning it in a systematic review. But they didn't focus, none of the authors focused on proprioceptive training, but focused on coordination, strength, and mobility, which is typically where a lot of the myofunctional therapists do focus on, going straight into a myofunctional therapy program, mainly by prescribing isometric and isotonic exercises. Only one of the studies that they looked at, because this was a systematic review that was included in a systematic review, okay, only one of their studies compared 3 different sets of oral pharyngeal exercises and concluded that there's no difference between the programs. So it turns out that like some of these exercises, it's really similar, right? It probably wouldn't be hard for us to create some standardization in the field. However, their design had important flaws that prevented us from drawing sound conclusions. Like, shouldn't that have excluded it from your study? I don't know. That's fine. First, the effects of training were progressive, and the highest percentage of improvement in symptoms achieved by patients in the last phase of treatment compared with the previous 2 phases didn't indicate which set of exercises were most effective. And the patients were not randomized, and the sample size was small. These are my biggest issues. These are my biggest issues. Whenever somebody brings something up to me with like a research or whatever, and I love talking about it in the Myopathway group and cohort that we have, but if you're looking at research and you're looking at it with a critical eye and you start looking at these sample sizes, you're like, these are a bunch of case studies. These are easily a bunch of case studies. I see more hygiene patients in a week than they looked at for this entire 6 to 9 month study. And it's not randomized. And like, what is the criteria? Or if we have the criteria, who's repeating that? Nobody. That's not the way that our standardized education system works, right? So I love that in that one systematic review included within Zoggy's systematic review, there's a whole table, and the table is like 3 pages long because these are landscape view. But the table has all the protocols that were used. And so this is amazing. This is really great to look at, okay? So when you're looking at all of these protocols, right, you're looking at the duration of time. It varies. So 3 months, 3 months, 6 months, 4 months, 3 months, 3 months. You guys will note that myofunctional therapy, most often it's touted as something that has to be done for a year. Some of the major organizations are swearing it has to be done for a year. Well, that's funny because all the research that everybody keeps pointing to, who's doing it for a year? Everybody's doing it for 3 months. And we don't know what it is. And then when you do have the one for the pediatrics, it's 24 months. That's 2 years. So where do we pick a year from? Just out of thin air, right? That's where we pick that number. It's got to be a year. I don't know. Seems like it must have been out of thin air. Then the sessions. Look at this. Sessions 7 days a week, 4 times a day. 7 days a week, 4 times a day, 30 minutes, these sessions. Controlled studies. You got to love it. And it's heavily interesting. Okay. The 3 times a day with no sort of active length, 10 times a day, 10 repetitions each exercise, 1 session a day for 20 minutes. So every day, just once instead of 4 times a day. And then the visits, what supervised, unsupervised, is just at home. How are they being utilized? So this is really interesting, and you can always pause when you go back to watch the recording. You can pause and like really read through it and dive into all the different protocols and the random sources of wherever they picked up this information for the exercises and how long we do it and how long we prescribe it and how many visits we have and how many times, and we're going to exercise this amount and we're going to do that. It's mind-boggling. And it's got to lead you to the idea of that myofunctional therapy, 1, in a thing, but 2, it's a lot simpler because all of these studies came to the conclusion that myofunctional therapy works. It works based on these particular protocols that they're doing, as varied as they are. It works, but it's only a couple of months. So you know what I said the first time I started looking at this stuff, and that was like a year plus ago when I started looking at it. I'm like, why do we have these ridiculously lengthy programs to become oral myofunctional therapists when it really could be a lot simpler? I don't know. Why are we making it so hard on ourselves? Why are we making this so incredibly impossible to the point where people are so confused as to what they should be doing. Can't it be simpler? Yes, it can be simpler. Okay. Let's get real. All of your favorite studies, all of the things you are quoting, typically contain somewhere between 7 to 10 exercises. If they list all their exercises and the protocols, if they don't, you have no idea what they're doing. You don't know the frequency. You don't know the cadence. You have no idea what's going on. But 7 to 10 exercises, you can create a program like that. And guess what? It already exists. For less than $500, you can be a myofunctional therapist. MyoMindShift. MyoMindShift's been available for well over a year. There are 7 now. I've added 2 since it first came out. It came out and it was only 5 different exercise programs, but you could target specific things. You have somebody with sleep disordered breathing, guess what? There's a protocol for that. And it's 2 to 3 months. All of these, TMD, breath work, pediatric, cheeks, 2 to 3 months, several exercises, mimics a lot of what the research is. And you can be a myofunctional therapist doing the limited set of like peer-reviewed, tried and true research that's out there. I mean, or you could always, set a new standard and go and do a bit more than that and become pretty comprehensive at being able to do things like work with proprioception beforehand, cranial nerves, understand these special cases and how to work with people who have genetic disorders that are going into oral surgery and ENT and all that sort of stuff that I deep dive into in a course that is unlike any other, and that includes on-site, in-person, hands-on education. So whether it's me coming to you or you coming to me, it's a no-brainer as far as I can see. But we're not done yet, okay? Don't leave me yet, all right? Pseudoscience. I want you to think about this. I want you to think about myofunctional therapy and where it is now. I know we're over time, but I promise you we're ending in the next 10 minutes. Hopefully I'm not lying to you. Pseudoscience. Pseudoscience can't be proven wrong. It's vague, right? So oral myofunctional therapy, just calling 7 myofunctional therapy exercises you have people do twice a day, every day for 2 months is not myofunctional therapy. But when you call it that in a paper, I can't really prove you're wrong, right? Especially if I don't know what oral myofunctional therapy is or what that really looks like. But it's being called that in this paper with some oral pharyngeal exercises. Relies heavily on antidotes, personal experiences, and testimonies. I dare you, I triple dog dare you to go to any social media account with myofunctional therapy content and to find something that is not a personal experience, some testimonial or an antidote. You can't find one thing that is based on research. You can't. At least not for adults. Children, sure, but they're malleable. And there's a lot of other influencing factors. And so you would have to prove that out to me really heavily because I know how to read research. Okay. It cherry picks confirming evidence, like doing a systematic review, where in one of the reviews is a review that says that myofunctional therapy just isn't really a thing. So that's cherry picking your evidence that confirms. And it lacks no way to explain it based on existing knowledge. It would, like, no paper describes oral myofunctional therapy the same. We really just don't have the evidence behind it. It is a pseudoscience, people. It's really important to learn how to read a paper, a research paper. Make sure you're checking your sources. Make sure you're reading them out. Do not send out blind research. It is the worst mistake you can make for your career. The sooner you adapt that it's a pseudoscience, the better off you will be. Because guess what? Other more popular pseudosciences exist, and they exist without contention. Nobody is battling me on Reiki. People will pay me for distance Reiki. I do Reiki and energy work sitting behind a screen. They're on the other side of a screen and we connect. I'm able to tune into them. We become attuned to each other and I can clear out the chakras through energy work. And some of you are going to be like, that's nonsense. But guess what? More people are into that than are ever into myofunctional therapy. And it's so easy. It's so easy. I don't have to fight with them and provide research and talk about this, that, and the other, and what doctors are behind me. No doctors are behind me. It's energy work. We believe it because time has really proved it. I'm a firm believer. Reiki has done wonders for me and many of my patients. Can I prove it? No. Will you like to do it? Most people say yes. That's it. Sound healing, very similarly. A lot of these have overlap. I don't do sound healing, but you see the overlap with like improved sleep and helps you think more clearly, gives you more energy, improved mood, helps with people undergoing surgery. Like, with what data do you have that you could really say that? But you don't need it. There are no references here. There are no references here. And nobody's ever going to challenge it because we've seen the Kardashians do sound healing. Or because we understand that Reiki is energy work and we associate it with Eastern medicine. And so therefore we kind of understand. That's where Myo needs to get to. It's not a thing. It's a pseudoscience, and being a pseudoscience isn't bad. It's just you have to learn how to communicate more effectively. That way you get people to work with you. I can have doctors refer to me for simply Reiki alone on the basis that this person I'm working with is more holistic, isn't going to follow any of my protocols. They're really struggling, and I don't know what else to do. So I sent them to you and see what you can do with them. Awesome. I'm going to talk to you about Reiki, cranial nerves, rhythmic movement. I'm going to talk to you about all the things, the myofunctional therapy, under the guise of, I know it's a pseudoscience. I'm not going to try to pretend that I'm talking to you from some high level of research place. It's not evidence-based. Okay. This, friend, is what we do. I thought that was cute. Pseudoscience. This is what we do. And I think there is a really great documentary. If you have Netflix, and it's very expensive, very stupid now, and I might cancel very soon. But if you have Netflix, there is a great documentary you can watch with a bunch of other pseudosciences that presents it from such an objective place that I promise you, if this didn't help you look at what we do more objectively, it will help you. It's called Unwell. And Unwell has all these different things in it. So whether it's essential oils or Ayurveda, ayahuasca, or bee stings, all of the things that people swear by because this is the way, the truth, and the light. Myo's not the way, the truth, and the light. It is one little method that can possibly help some people with some fantastic happy accidents. But the one thing it definitely does that nobody's ever put to test is it helps with proper oral resting posture. Proper oral resting posture needs to be your end goal with any sort of explanation that you're ever giving to anybody on this topic. With that, I know we're a little over. With that, I'm ending. Okay. If you have any questions, feel free to reach out. If you are still kind of unsure, rewatch. But it's a pseudoscience. It's what we do, and we are very good at it. May peace be with you, all of my Myo friends. Until next week, have a fantastic week.